good afternoon. My name's Marilyn Pierce-Bolger, and I'm a family nurse practitioner and certified nurse midwife who's been practicing here in Alaska since the 1970s and have really focused on FASD-related work now since the mid-1990s, when I actually got involved with that through the infant mortality door. I worked at the old Alaska Native Medical Center, and native infants were dying at 3 times the rate of non-native infants here in Anchorage. And the hospital administration asked myself and the public health nurse if we could figure out what was happening. And in the course of doing that work, we really began to get to know the women that were struggling and recognized that a significant percentage of these moms had an impairment and really were struggling to be independent and live on their own and certainly parent. So in the course of that work, I learned more about FASD. And fast forward to 2020, I've now been involved with both the prenatal side of working with clients related to FASD, as well as I've been involved with doing diagnosis for 10 years with the Anchorage FASD diagnostic team, and then founded the nonprofit, the Alaska Center for FASD, a few years ago, really to provide support and more information to the community around FASD, which is a preventable disability. So I want to talk to you today about a product that was developed here in Alaska, and we actually are recognized here in Alaska as being experts by the rest of the country because we've been doing work here since the 1980s, and there's really been a commitment looking at how can we shift things for individuals. We need the medical provider community to really get on board with FASD prevention, and I have clients even today who are telling me that their medical providers are telling them that a little alcohol is okay in pregnancy. And really that is not the case. And the reason for that is we don't have a crystal ball. We don't know what this mom's genetics are. We don't know any epigenetic influences that might have influenced her family with regard to reproductive capacity and how that might be influencing her. We don't know the issues around or the details related to her micronutrient levels. We may be aware of other medications and maybe perhaps other substances she's combining with alcohol, but really there's just a lot of questions. And so we really do recommend that the message needs to clearly be that there's no safe amount of alcohol and no timing during the pregnancy when it's considered safe. So I just want to talk to you a little bit about how you can have these kinds of conversations with your patients. They do not have to take a lot of time. And I know you're busy, I'm busy. We get pushed into a 15-minute appointment with a client and we have a whole lot of things to do. And this is just one more thing we're asking you to do. I know that. But I really think that we can make a big difference if we're working on this together. So the Let's Talk FASD AK campaign started a number of years ago with funding from the Alaska Mental Health Trust, and the contract went to Northwest Strategies, who's developed these fabulous products that I'm about to show you. This website is available through the Alaska Center for FASD website. We're merging these two websites because we at the center are also committed to FASD prevention in addition to intervention and support for those who are already impacted. So I want to talk about the guidebook specifically because it can give you some ideas for how you can have this conversation. And it doesn't have to take a long time. The other thing that's on the website is information related to motivational interviewing. But motivational interviewing, and you'll see video clips on the website, they tend to be a little bit longer. They may be 5-7 minutes. That's not what we're talking about here. We're really talking about brief intervention, doing some alcohol screening that's useful in getting a sense about quantity and frequency and how much her alcohol use might be impacting her day-to-day life, and then using that information to help her see how that might be putting her at risk for an unintended pregnancy and or an alcohol-exposed pregnancy. So the guidebook is a flip chart product, spiral-bound flip chart, and we know that there's about 400 of these out around the state. And if you're like me, you may have gone to a conference or some other location where you saw something you really were excited about, and then you just didn't have the time to implement using it. I get that. So that's why I'm making this video, is to try to make this easier for you. So this guidebook has basically two strategies that are available for you. One is for a woman who's pregnant, and the other one is for a woman who's not pregnant. And really, we want to message both of these individuals. Even for women who may be screening as having very low risk alcohol use, I think it's important that we let her know what the risks might be, so that she can spread the word, and we can ask her to spread the word to her friends, because there's a lot of misinformation out there, and we as health professionals want to make sure that we're not contributing to that misinformation. One of the things I'll say about the booklet in COVID times is that this is produced with using paper that's easily sanitized. So if you use this, even if you use 1 or 2 pages of it, whoever's cleaning your exam rooms behind patients can take a quick wipe over this and have it ready for another patient. There's use of a tool called the Audit, which is Alcohol Use Disorders Identification Screening Tool. It's really the standardized tool that's recommended today by the Centers for Disease Control. You can use it in a variety of ways. It's actually includes 10 questions, but you're not asking her all 10 questions unless she screens above a score of 7 on the baseline 3 questions. And if you're working in a healthcare system that's really not supporting you to do alcohol screening, which is possible, or who can't integrate that into their healthcare, their electronic health record easily, or their records easily, you can use just question 3 from the audit as your own screening. And that question is, how often do you, and you're talking to the client, in the case of a woman, have 4 or more drinks on one occasion? And she's telling you either never, less than monthly, weekly, 2 to 3 times a week, 4 to 6 times a week, or daily. Depending on which of those answers she's giving you, you're getting a numerical score that then allows you to determine whether you ask any other remaining questions, and or whether or not you might be concerned about her having heavy alcohol use. But really, with the audit, we're aiming for identifying women who may have just at-risk usage, and men as well. The other thing I'll say about the audit is that it's validated down to age 12. So if you happen to be a family medicine provider and you're working in a practice where you see a fair number of adolescents, you can use these same questions with teenagers. So I would encourage both the pediatric and family practice communities to do that as well. So the other 2 questions, screening questions, for the 3-question audit include, how often do you have a drink containing alcohol? And again, it's the same, either never, less than monthly, weekly, 2 to 3 times a week, 4 to 6 times a week, or daily. And how many drinks containing alcohol do you have on a typical day when you're drinking? So those answers are 1, 2, 3, 4, 5 to 6, 7 to 9, 10 or more. I will tell you that many of the patient population we work with, they don't understand that really it doesn't take very many drinks to be defined as a what we call binge or high risk use sort of pattern. And for women, a binge is considered more than 3 drinks on one occasion, and for men it's more than 4. So that may be a Friday or Saturday night that somebody's just drinking with friends and enjoying the evening. And they're just not aware of the fact that that level of alcohol may be harmful both to them in terms of increasing the risk for their personal organ or physical injury. But if she happened to have, say, an unanticipated pregnancy and doesn't realize it yet, that could be an alcohol exposure that's a significant exposure, certainly, for an early pregnancy. So let's talk a little bit about how you might go about doing this. One of the things I would say is that if you're in a practice where you can incorporate the audit into your patient check-in process, I would do that, because you asking the question yourself can set up a barrier where you may not get as good of information or as honest information from her as you can if you can make it more anonymous. I'm working with a project down with Centers for Disease Control funding, looking at the Planned Parenthood organizations in the Northwest and here in Alaska. And Planned Parenthood's actually chosen to integrate their this alcohol screening tool into their mobile check-in process, so that before the client ever even gets to the clinic, the questions are actually getting activated. And if her score is above a 7 on the first 3 questions, then it's queuing the next 7 questions for her to answer before she sees the provider as well. So that, there's different ways to do this, and certainly you can ask the questions, but if you can put it into a paper pencil format, you may find that gets you better responses. And then one of the things I think that's important is telling people that this is a question you're asking everybody. You're not targeting her. You're making no assumption that she's a woman who might be drinking. You want this to be a routine part of your practice, and I would encourage you to be doing this with men in your practice as well, not just women. The more we just do this routinely, the easier we have in terms of being able to have the conversation and come up with a few phrases that work for us. One of the introductory things, let's say she's filled out a paper version of a screening tool before you get in the exam room, and you've been given that information by the person who roomed her. You can take a quick look at that, and you have a sense about what that information is before you walk in there. One of the ways to approach this is to say, hey, I see you filled out some intake paperwork for us. Do I have your permission to sort of show you what the answers are and what your alcohol use looks like compared to low risk or high risk patterns? And you'll get either a yes or a no. Most people are interested in having their healthcare provider be honest with them about what might be going into influencing their health. And so our role is to plant seeds and to help clients be thinking about things that may be putting themselves at risk. So if it's a non-pregnant client, you can certainly have the conversation around, I see you're having more than 4 drinks on occasion a couple days a week. And for a woman, having more than 7 drinks in a week is considered risky. And if you're having that as a bolus, if you're having most of those drinks on one day or one occasion, that level of alcohol is harder for your body to process. Tell me if you'd like to be pregnant in the next year. One of the things to combine with alcohol screening is particularly for women who are not pregnant or don't want to be pregnant, is asking them if they want to be pregnant in the next year. If you're not aware of what they're using for contraception, finding out about that and or making a recommendation for them about what might work with their lifestyle and what works for them. We know from research done with CDC-based projects that long-acting reversible contraceptives combined with screening and brief intervention have been very effective in terms of decreasing risk for alcohol-exposed pregnancies. And so if you can combine those 2 elements in your practice with those 2 simple questions, that can be really helpful. Ideally, if you have time and you have the 3-question audit, which then cues to the 10 questions, you're definitely getting more information and have more information with which to frame the conversation with the client, depending on why they came in for their office visit. Let's say somebody came in because they have an STD, or they have symptoms they're concerned about. Was there some sexual activity that they had related to their drinking that might have increased their risk? And you don't want to do this in a shameful way, but you can shift. You can have a conversation, helping them put 2 and 2 together around, if you're drinking alcohol in a more heavy manner, that may be influencing your ability to protect yourself and keep yourself safe. What might be some things that you could think about to do that might reduce your risk? Giving some suggestions for alternatives for how she might be using alcohol. If she's out with friends and everybody's having mixed drinks, she might consider asking for an alcohol-free mixed drink every other drink, or go drinking with a friend. There's a lot of strategies, and on the website, the Let's Talk website, there's a lot of information out there about things that you can suggest or that you could present to her as ideas if you have that part of the conversation. But again, you don't have to go there. The idea is just to get a sense of how she's using alcohol. Is she using alcohol above the recommended 7 drinks a week or more than 3 drinks per occasion? And if she's doing the higher, the at-risk drinking or the high-risk drinking, helping her to see how she falls on the continuum. One of the things, if you're having conversations with clients who aren't pregnant, let's say. And you just want to give them some information or a visual as you're talking to them. And I'll tell you, I really like to do that because we've got lots of folks who are not audio learners. They're not auditory learners. If she's got a score of more than 7 on her basic 3 questions, she's going to fall in the level 2 range. And you can show her that on the pyramid. You can also show her and or him what kinds of organ impacts there might be related to the heavier use of alcohol. That may be enough to help, sort of plant the seed for them to be thinking about doing something differently. Let's say you've got a client who's pregnant in your office. So this is not a screening for an annual or contraceptive visit or STD visit or something. One of the things to ask the woman is how much alcohol has she heard is okay to consume in pregnancy? Because there's a lot of misconceptions out there. And women are influenced by a lot of people, including you, but other people may, or other entities may already have had some influence on her in terms of saying a little's okay, or it's okay in the early part of the pregnancy, or it's okay in the latter part of the pregnancy. So try to get some sense about what she might be thinking or knows. As part of your new prenatal or your prenatal intake, most of us are doing a little bit of risk screening anyway to identify whether or not she's got other harmful behaviors she might be doing. And we all are having conversations about the basics around what kinds of things might be harmful to an early gestation, for example, hot tubs and those kinds of things. Anyway, the bottom line is alcohol is part of that screening process. The audit, as I mentioned earlier, the audit, 10-question audit, can be really helpful to have a conversation with her. Again, you're not asking all 10 questions. You're asking her to think about her alcohol use in the last year. What's her pattern? How often has she had a drink containing alcohol? We know from the research that what her drinking pattern looks like prior to pregnancy is potentially predictive of what her drinking pattern could look like during the pregnancy. But I will tell you that most women do stop drinking during pregnancy once they realize they're pregnant. So our messaging needs to be to continue to support that they not continue to drink and that they don't have more. The second question is, how many drinks containing alcohol do you have on that occasion? So if she's having 1 drink, that risk is less than if she's had 5 or 6 on a Friday, Saturday night with her friends. And again, early trimester exposure does matter. I'm less worried about the woman who's had the glass of wine at a wedding than I am about a woman who went out and had multiple drinks on Friday and Saturday night with her friends. But we can't predict which of those amounts of alcohol levels might be influencing either one of those women's pregnancies. And so I think we can't tell her what her risk is specifically. We can tell her the risk is low, but it's not 0, and that's why we recommend no alcohol at all during the pregnancy. There's a fetal development chart in this guidebook that is really helpful. For those of you who got the guidebook already, the original print run of those 400 had a fetal development chart that went up to 38 weeks. That was the original iteration that was produced by the Centers for Disease Control. That was judged to be confusing to our patients because everything else we do is focused on the 40-week calendar based on the last menstrual period and year cycle. So I just want to point out that if you've got one of the old guidebooks, you can download the new fetal development chart from the website, and it does have the 40-week calendar in it. And the thing that's neat about this is that you've got each of the gestational and trimesters sort of laid out with regard to what might be the areas that are the focal areas where damage may have occurred or could occur if alcohol is happening. What I basically tell health providers is that the first trimester is largely focusing on the structural and malformation sorts of issues related to alcohol. The fetal brain is sensitive the entire 9 months. In the second trimester, the neuron development is what we know is happening significantly. And if those neurons aren't being developed then, they're not getting developed later either. So it's really critically important that if she has had alcohol early on, to reinforce the message not to be using after she realizes she's pregnant. Third trimester exposure tends to impact dendrite formation and cerebellum functions, which can include memory and balance and motor coordination and things. So anyway, I think it's important that we're honest with our patients. And if you have a client who's had some alcohol exposure prior to pregnancy recognition, I think we should say that we can't predict whether or not this has been a problem for this particular mom and baby, but that we want her to know that the risk is not completely zero, and that she should at least be mindful about watching the child's development over time. And if there are things that are showing up with regard to behavior regulation, attention, learning, or social problems, those things may be related to an FASD, and we want to make sure that the child gets intervention for those. And that she needs to make sure healthcare providers who take care of her child know that the alcohol is part of the story. As an OB provider, for those of you who are working in prenatal field where you're actually doing new prenatal record management, I would recommend that you consider using the ICD-10 codes, which are outlined here in the guidebook, to flag the prenatal risk record so that it's in the prenatal risk record for transfer into the newborn record at the time of delivery. Our pediatric colleagues really struggle when they are seeing clients who are having multiple symptoms, but we don't have the alcohol story as part of what might be needed for the differential. So I really think, and we have our own stigma and judgments around putting the alcohol story or the alcohol flag in the prenatal risk record. And I think by normalizing alcohol screening and by normalizing the conversation, talking to individuals who have FASD about what they would ask us to do differently, I'm telling you what they're asking us to do differently, and that is be upfront about this and help women understand that we're not doing this as a label or to do anything punitive with them. It's for the best interest of their child as they're followed long term. I want to just point out there are several materials available that are downloadable on the website. One of my favorites is the Let's Talk mocktail flyer. You'll find this in resources. And so for women, when they're trying to come up with suggestions for what else they could be doing, and this is particularly helpful for a prenatal client as well, because when we're asking her to stop drinking, we may be asking her to alter her social life in some way, and that may be really hard for her. More and more establishments are offering non-alcohol versions of cocktails, and asking for those is a terrific, is something that we can do. Some restaurants actually have those menus. They may not put them out, but they may be available, and bartenders like making them. The other thing is to have her recommend that her partners stop drinking during their pregnancy, so that she's got somebody who's walking that path with her and helping her do that. One other point I want to make sure we're making is that I know that we as providers may make assumptions about who's sitting in that exam room, depending on what we know about their story or how they might look, or what they say in terms of their history. And having an alcohol-exposed pregnancy can happen to any of us, including women who are, white, working, college-educated, very intelligent individuals. And part of that is because the misinformation about alcohol use in pregnancy is very prevalent. But the other piece of that is that the alcohol industry has marketed to women really aggressively over the last 30 years, and it's worked because more of us are drinking. And more of us are drinking in a pattern that kind of matches how men are drinking. So we're drinking in these patterns that are higher dose, higher risk sort of patterns. Maybe just a Friday night with friends or clients. But that pattern can be a problem, particularly if the contraceptive method is one where she's not able to use it really consistently. For example, if you've got a birth control pill user who's forgetting pills, that's a recipe for a problem. And we know that methods can fail for a variety of reasons. So we used to say, we used to say that FASD was 100% preventable. And then we realized that was a stigmatizing statement because things happen. And so what we want to do is help women understand that you can just be living life, and it could be that you may be at risk for an alcohol-exposed pregnancy and don't realize it. So we want healthcare providers to make sure that they're conveying messages and thinking about the fact that any reproductive age woman is at risk. And don't make assumptions that she's not using alcohol in a risky manner without asking her questions in an organized fashion like what we're recommending with the audit. One of the things I'll say about the guidebook is this thing is super easy to use. And if you're in your infancy with regard to learning how to have conversations related to alcohol and preventing alcohol-exposed pregnancies, there's some wonderful tips in here. As I mentioned earlier, the book is really just divided into sections related to, is she pregnant? Is she not pregnant? You flip to that section. There's some great visuals. There's also some good links here that they tells you where to go on the website to get handouts and other things to give her. So you don't have to do a ton of work. It might be helpful for you to practice doing this with somebody on staff and get yourself sort of set up so that you know what resources you might be using frequently. Like for me, I tend to use things like the alcohol use guide and the mocktail handout and those kinds of things. Whatever you might find, and the fetal development chart, clients really like that too. So if you have some things that you like to use and would use frequently, then put those where you can grab them easily. And so the book has a lot of the handouts noted in them and the tips, and we hope that you will consider using it because it's free and it's a fabulous resource that can make you be a better provider with regard to how you have conversations around alcohol use and preventing alcohol-exposed pregnancy. I'd really like to recommend that you visit the website. There's several things on there. We're going to be making a couple of videos where I'm demonstrating how to have this conversation, just the quickie conversation. And again, it doesn't have to add a lot of work to your life. You just have to practice with some phrases you're comfortable with. The other thing that's on the website, and there's a bunch of videos that are related to motivational interviewing techniques and strategies. You might find phrases there that you like. We're also, there's a lot of downloadable material. There's a lot of links if you have clients who you are finding who are high risk and you aren't sure what to do about like referrals for treatment intervention. There's some nice risk links or treatment seeking links in the site as well. So you don't have to have all this information in your head. You can simply bookmark some places on the website that you particularly might like to use and then use them. Let me just tell you about some of the materials you might have also received with your guidebook. There's several posters that are nice to put in exam rooms because it lets the patient know that you're open to talking about alcohol use. And it also gives her some information while she's sitting there waiting for you to come in. These stickers are pretty clear in terms of saying, hey, this could be any of us, and we need to be thinking about this and mindful about it. And they are a product that will come off a wall. So if you stick it on a wall or computer or someplace, they're not stuck there for life, unlike some of the glues that we use with products. One of the things I'll say about alcohol and pregnancy is women are more stigmatized for their alcohol use than men are. And I've worked with a lot of birth moms over the years, both as a nurse midwife and during the time when I was doing FSD-related diagnoses work. And women have told me that if they are the alcohol-using woman in the hierarchy of women who use substances, let's say at Highland Mountain, they are the lowest rung on that hierarchical ladder. And so we have to do more to dispel the stigma around this. And you, the provider, play a role in this. And if you can help get yourself more comfortable about having these quick conversations, reassure her you're not judging her, and that you are somebody that she can confide in if she's struggling and having a problem, she may not give you a straight answer right away. And you don't have to have all the answers back for her. But the good response is, if I don't know it, I'm going to try to help you find the answer for that. I want you as the provider to think about the key takeaways from what I've been saying today. And I think the big messages are, you play a key role in helping women to have correct information about alcohol use and pregnancy. And I urge you to get informed and find a few phrases that you're comfortable using that can help convey the messages. I also want to be very consistent and very clear that there is no amount of alcohol and no kind of alcohol and no timing during the pregnancy when it's safe. And we have to be really black and white about that message. The other thing is that I think we have to be very mindful that any woman in our practice may be affected by an alcohol-exposed pregnancy. And we want to manage that in a very kind and careful and non-judgmental way and help her to understand the risks for her child, what the strategies might be to follow them long term. If she's super high risk in terms of her alcohol use, help make referrals to get her to treatment and support her in treatment. And finally, I think we want to make sure that we ourselves understand that FASD is preventable and that it presents predominantly as a hidden disability. The facial features are not a common presentation, and that's because those only are impacted in the 3rd week of gestation. The brain is impacted the entire 9 months. The brain impacts show up as attention, behavior regulation, adaptive living, learning, and social difficulties. And those are the things that show up over time that we want to try to prevent.